now call upon Dr. Krishna Prasad Kudlu for his presentation. Dr. Krishna Prasad Kudlu is somebody who needs no introduction, chairperson of the ARC. We get emails for him from the ARC proceedings every day. He's also the president of Karnataka Ophthalmic Society. Over to you, sir. Sorry. Thank you, Dr. Sharath, for correcting me. Chairman proceedings, not ARC.
Thank you, Dr. Vikram. I think in continuation of troubleshooting post-cataract surgery, so I'll be talking about how I tackle the post-cataract surgery refractive surprise. So, what exactly this refractive surprise, which is the failure to achieve the intended post-operative refractive target. It can even cause anisometropia or dominance switch, which is a source of a patient for dissatisfaction. If you see the benchmark standard, what has to be? Around 85% of the eye should be within 1 diopter, 55% within 0.5 diopters of target spherical equivalent refraction following a cataract surgery. So, always prevention is better than cure. The best way to manage refractive surprise is prevent it. One important, accurate biometry, a constant optimization, selecting a proper intraocular lens formula, and also avoiding wrong lens implants. So, once there is already refractive surprise, you should identify the cause. First, the formal subjective refraction is essential. Thorough dilated examination to identify the surgical causes, like look for tight corneal sutures, whether you place the intraocular lens in the sulcus or in the bag, or there is a distended capsular bag due to retained viscoelastic that can also cause myopic shift. Sometimes presence of any corneal pathology like corneal scarring or corneal edema, which can influence the refractive outcome. Of course, postoperative cystoid macular edema even can cause a hyperopic shift. So, now review the refractive history and take out your biometry values also, the IOL selection process, and also look for the surgical record. Whether wrong patient biometry has been entered, see for any transcriptions error, selecting the lens from the ACIOL column, that also important. Incorrect A constant, also incorrect formula what you have picked for that particular patient. Then you should check for the axial length by repeating the biometry. You should check for abnormal keratometry. Sometimes what happens, the presence of high case or astigmatism, that means you might have missed the pre-existing keratoconus in that patient. If there is no error, the refractive surprise can be attributed to the effective lens position, and similar error can happen in the fellow eye too. So, coming to the management, this is very important. Whenever there is a refractive surprise, always better to openly explain to the patient an apology. But this is not a declaration that you have done a guilt, but you have to tell him that it has been happened. Let us see how we are going to manage. Sometimes best way, you take a second opinion from your fellow colleague, that makes their tension little bit on the lesser side. So, what are the options? So, doing nothing is always a better option. Many refractive surprise do not require a surgery. Suppose if you leave behind some low myopia, we can convince them that they will have a very good near vision. Suppose a patient who has already worn glass in their life may be willing to continue wearing glasses. Sometimes when the patient already wearing the glass, when they come to with the refractive surprise, if you won't mention them, after 1 month of post-op, just give them the glass, they will be very happy. They will be keep getting more number of patients to you. But the benefits and risk of intervention, this also you have to explain to the patient very well. So, coming to the management side, again correcting the surprise depending upon the comforts of the surgeon, which intraocular lens has been used, how long it has been since the lens was implanted. This is very, very important. So, first if you have got a already retained viscoelastic, this is the only indication you can do a early yak capsulotomy that can disperse the viscoelastic and allow the anteriorly displaced intraocular lens to move posteriorly. Coming to the corneal refractive surgery, I think this is I can feel one of the best option, because I do have got a excimer machine with me. But whenever you think about, okay, you want to do corneal refractive surgery, whenever there is a residual refractive error, always better to wait till 3 months. In spite of, I have done in 1 month also, but now I am telling you to wait for 3 months. For a small amount of residual refractive, or even you can do PRK, or if you have got a femto platform, femtoLASIK can be done. So in older patient, it is always better to do a PRK, because they might be already having dry eye. You should not be again increasing that dry eye problem. For younger patient, if they are having around a residual error of -3 or -4, femtoLASIK is one of the good option. So coming to the ablation profile, lot of studies has showed that wavefront guided treatment gives much better results than the topo guided treatment. According to the Generita et al. Evaluated the outcome of wavefront guided treatment with iris rigid station after implantation of different multifocal intraocular lens in 27 eyes of 19 patients. They found that patient already been implanted diffractive multifocal intraocular lens, so they did very well after the wavefront guided treatment. So always LASIK seems to be very safe if you already done the yak capsulotomy, because once you do the yak capsulotomy, what Dr. Sunil had shown, the IO election sometimes has become difficult and has got a greater risk, because you may not be promising the patient that you will be putting again within the bag. Once the LASIK flap has been established, then additional optical adjustment also can be performed successfully. Normally what happened in femto, especially I do have got a Visumax, where the amount of intraocular pressure it puts over the cornea is around 25 to 30 millimeters of mercury. So you can make the flap, you can do the with the excimer laser, you can polish the whatever the power. Suppose again any problem happens, you can lift the flap back and you can again re-enhance the treatment. So what are the limitations again for laser vision correction? If you have got a high refractive error, again you can't do, and even patient with a low corneal stromal thickness also you cannot do. Of course, the very important thing is you need to have this excimer machine in every clinic, which is not going to be possible in this era, and even extra cost to the doctor and not for the patient, because you cannot charge, especially if you are having this kind of problem, you have to do it free of cost to the patient. Coming to the intraocular lens exchange or piggyback, so of course it is effective in reducing the high degree of spherical error, because lens exchange never going to alter any corneal surface, do not change the corneal refractive power. So you don't require any special setting what we do with the excimer laser. But add-on sulcus lens now have been becoming more and more popular, something called a piggyback lens, which can be implanted in the sulcus over the original intraocular lens. As this corrects the manufactured refractive error, the power of the you need not have to know about the power of the original lens. So these piggyback lenses are less accurate than, of course, than the laser refractive surgery, but good for, especially for high degree of error. So always I avoid the risk of IOL exchange, as those who have already with the ocular surface disease, and which is there not suitable for laser refractive surgery too. So the problem with only with these piggyback lenses, I have done a lot of piggyback lenses in the past, but some of the patients come to us with something called pigment dispersion. You may have to tackle them with a long course of steroids. So of course these piggyback lenses, especially someone from the Rayner, these are quite expensive. I think you have to bear those costs also. Coming to this sulcoplex lens, which has become more and more popular, which is a spheric pseudophakic supplementary intraocular lens. We put it in the sulcus, which is especially helped to correct the residual post-operative refractive error, because once one patient has been underwent multifocal lens in one eye, had come to me, said that my near vision is not good, I don't want any sort of other procedure apart from this, then I have to really pick a trifocal platform in this sulcoplex and implant it in the other eye, patient doing very well. So these lenses are a little bit helpful even for those who really doesn't want to wear the glasses. In conclusion, if you nutshell, I want to tell, laser vision correction has been shown to be a viable, non-invasive and accurate procedure to correct the emmetropia after cataract extraction with IOL implantation. Lens-based procedures, IOL exchange or piggyback lenses implantation are possible alternatives. Piggyback intraocular lens, technically easier, but more accurate than the IOL exchange. You need to remember that, which is better indicated cases with extreme emmetropia, corneal abnormalities, and when there is no available of examiner platform is available. Thank you.
Thank you, sir. By piggyback lens, which lens are we talking about? Sulcoflex or?
Sulcoplex.
I think now that we have our phakic IOLs in very low powers, they are the easier option.
Yeah, this is one of the thing. Again, see, from IOCare already designed a phakic lenses which can be implanted over the already over the in the sulcus.
They start from one day up
Yeah,
now.
But again, I have experienced in a couple of patients with same lenses, pigment dispersion is much higher compared to the these what I told the sulcoplex lenses.
Okay.
So I think the whatever the phakic lens, I think we have to keep in the last option.
Okay.
If you are having a very high refractive surprise, we cannot do the IOL exchange, then I think probably the phakic lens is the best available option. Because what you do if you are already having the astigmatism, you are putting in the sulcus, sometimes these lenses may rotate. Again patient may come back with you some amount of astigmatism, then you have to re-rotate, or you may have to do the again exchange of that phakic lenses.